Good afternoon. My name is Dr Lam, and I'm a professor of dentistry at the University of Toronto. I'm an oral and maxillofacial radiologist here, and I also serve as the Associate Dean for Graduate Education in the faculty. Today, our topic will be positioning your patient for a panoramic image. Thank you for the opportunity to speak to you today about panoramic image positioning. First of all, I wanted to just clarify a few terms. The image that we're going to talk about today, we call a panoramic radiograph, a panoramic image. Those are probably the two most common names for this image. Some people refer to this image as a pantomograph or an orthopantomograph. The word tomography or tomograph comes from the Latin tomos, which means thin section, which is what this image is. We tend not to call this image a panorex these days because the panorex system no longer exists, and we try and stay away from using the vernacular of pano. The tomographic principle is a fairly straightforward principle to understand. It involves a moving X-ray source, which you can see at the top of the screen, and a moving receptor. And nowadays, the receptor is a digital sensor. During the acquisition, the X-ray source moves from the L to the R at the top of the screen, and synchronously, the receptor moves from the L prime position to the R prime position. Any object that is located at the pivot point of the X-ray beam, and we call this the area of the focal plane or the focal trough, will stay in focus relative to the positions of the X-ray emitter and the X-ray receptor at the point B. So during the initial emission of X-rays, the red dot at B is projected onto the middle of the receptor, and as the X-ray beam moves from left to right and the receptor moves in the opposite direction, the position of the red dot stays constant relative to both the source and the receptor. Any object located outside of the focal trough, so if an object is positioned at point A, that image or that object will appear on the receptor in this position, but as the receptor and X-ray beam begin to move, that image will be smeared across the screen of the receptor, creating a very ill-defined and perhaps magnified image. Any object located at point C will do the same thing. So at the beginning of the acquisition, this object will be projected here on the receptor, and as the receptor moves, this object will be projected into this position, but smeared across the image as well. The panoramic concept, as this slide indicates, has actually been around for quite a number of years, over 60 years. It involves a very similar principle in the sense that there is a moving X-ray source and a moving receptor. The only difference is that the X-ray beam and the receptor do not move in a linear fashion, but they move in a curve that sort of almost simulates the curvature of the jaws. As the X-ray beam exits the X-ray tube, the X-ray beam is collimated and a slit X-ray beam is created before it passes through the patient. After the X-ray beam exits the patient, the beam enters a second slit or collimator before the information is deposited on the receptor. So these are two very, very interesting and unique features of panoramic systems. First, that the system moves in a curve around the patient that mimics the curve of the arch. And second, there is collimation of the X-ray beam at 2 points before and after entering and exiting the patient. Older X-ray systems that incorporated this concept utilized a series of pivot points that were located lingual to the tooth arch and the mandible. And the very first systems actually did this quite mechanically in the sense that half the image was created, and then the entire system came to a stop. There was a physical repositioning of the patient, and then the image continued on. But more modern day panoramic systems make use of almost an infinite number of these pivot points. And so today, when you look at a panoramic radiograph, the image looks virtually seamless because of the many, many pivot points that are created around the arch. The result is the creation of a so-called focal trough that isn't linear or planar, but it actually conforms to the arch of the patient's dental arch. The focal trough is unique to every different panoramic manufacturer system, although typically most of them are thicker posteriorly in the molar ramus area in the order of about 5 centimeters in buccolingual width. But in the anterior part of the arch, the focal trough is quite narrow, something in the order of only about 2 centimeters. So positioning your patient in the focal trough is really key to seeing all of the structures within the patient around the teeth and jaw. One way manufacturers have done this is that they have created bite blocks with little grooves at the top and the bottom of the bite blocks for the patient to put their teeth into. The location of that groove defines the center of the anterior focal trough. So if a patient is not biting within that groove, their incisors will not be within the focal trough, and you won't see those incisor teeth particularly clearly. Modern day panoramic systems also incorporate the use of either a visible or a laser type of light to help position. There is often a vertical light, which we align with the patient's midline. And most commonly when we do this, we align this with the contact between the two central incisors. Many people like to align this vertical line along the midline of the face, but some patients have crooked faces, some patients have crooked noses, and so, the reliability of that centering becomes less accurate if the patient is centered based on their soft tissue landmarks. There is also a horizontal landmark in which the patients can be oriented, and this will affect the way that their head is tilted a little up or a little downwards. Some people use the classic Frankfurt horizontal plane, which connects the tragus of the ear to the infraorbital rim. Others use a different line which connects the tragus of the ear to the ala of the nose. That second line tends to tip the chin up, and it tends to create a flatter occlusal plane on the panoramic image. Different imaging systems will recommend different horizontal alignments, and really this is a discussion that you can have with your vendor in order to determine the best horizontal alignment strategy. As well, some older systems may incorporate a light in the location of the maxillary canine. This is called the canine light. And there is a motorized platform that allows the patient to be moved slightly anteriorly or posteriorly so that the laser light aligns with the canine. The laser light is another way of confirming that the patient's anterior teeth are located within the focal trough. Nowadays, digital acquisition is completed on a computer screen, and this is one such interface. This interface allows you to select the size of the patient, the shape of the dental arch, and it allows you as well to adjust some parameters like the kilovoltage and the milliamperage or current of the imaging system. So if we look at the first option, which is program, newer panoramic systems will allow you to define how much of the panoramic image you wish to capture. So you can choose the entire panoramic image consisting of the mandibular rami and all of the areas in the maxilla or the mandible, or you can select segments within the larger panoramic image to capture. Second, and probably one of the most important adjustments that you have to decide on, is the size of the patient that you're imaging. Many panoramic systems will allow you to select for a child, an adolescent or small adult, a regular size adult, or a large adult. For us, we typically use the regular adult for most of our adult patients. It's very rare that we migrate either way. And for children, we often define children as being kids sort of under the age of 5 or 6, so very, very small children. What happens when you change this setting is you change not only the acquisition parameters, so the kilovoltage and the milliamps, but as well you change the size of the panoramic image that is captured. So if you have this set on a child setting, the dimensions of the acquisition will be slightly smaller than if you select adolescent or adult or large adult. So these are the KVP and MA combinations of this particular system. So you can see that the KVP will range from 68 to 83 KVP from a child to a large adult, and from 6.3 MA to 10 MA. These settings have been defined by the manufacturers of these systems, and you should use them and trust them. Some systems will allow you to define the shape of the patient's arch, and in doing so, small changes to the focal trough will be made to accommodate different arch shapes. Finally, after the patient has been positioned and you have selected the appropriate acquisition parameters, the last thing I typically do before I walk out of the room is I tell the patient to put their tongue up to the roof of their mouth. And by this, I actually mean I'd like you to put your tongue flat up onto the palate of your mouth, and we are going to see why in a moment. If you do everything right and you give the patient the instructions and the patient stays still for the acquisition, this is what you will see. As the patient's tongue is against the palate of their mouth, the hard palate, the density across the maxillary teeth, and particularly the maxillary tooth roots, is uniform, and there is no dark airspace within the oral cavity that can be visualized. If you don't ask the patient to move their tongue up to the roof of their mouth, you will see a dark or radiolucent area across the roots of the teeth. In some instances, this will obscure the roots of the teeth because the bone here is very, very thin, and the area may become overly attenuated or overly absorbed by the radiation, and it will simply penetrate the area too strongly, therefore masking the roots of the teeth. As I indicated earlier, the acquisition consists of a very, very thin collimated X-ray beam. So as the acquisition gets underway, this very collimated, attenuated X-ray beam arrives at the X-ray receptor, and this is the appearance of the acquisition on the computer screen. When it works, you should get an image that looks something like this, where the maxillary dental midline is coincident with the machine midline as indicated by the oval bite block, the image of which you can see between the upper and lower incisor teeth. If the patient is not biting in the bite block and they are biting too far anteriorly, what will happen is that the object to receptor distance for the patient will decrease, and the incisors will appear minified or narrowed, and the molars will appear very, very large. As well, you'll be able to see a very sizable portion of the posterior skull base, as well as the cervical spine. During acquisition, if the patient moves, you will see a jog or a disruption to the normal contour, particularly of the inferior cortex of the mandible. This often happens in small children who during the 15 or 16-second acquisition will just shift their head or open their mouth. For small children in particular, it's important to speak to them during the acquisition and simply coach them through the process, reminding them to stay still and to breathe gently through their nose. When a patient, again, isn't biting on the bite block, but they're biting too far posteriorly, so the bite block groove is located too far forward relative to their incisors, we will see magnification of the maxillary incisors and minification of the molar teeth. And that's what's happened in this particular case. Note how wide the two central incisors are here compared to the upper first or second molar. If the patient's chin is tipped up too high and their horizontal Frankfurt or tragus ala line is not horizontal, you'll see an upturn in the curve of the occlusion that will look like this, and the inferior border of the mandible will appear very, very flat. If the patient is rotated to one side or the other, the side that is rotated outside of the focal trough will appear blurry and magnified, and this is what has happened on the right side of this patient. And the opposite side may look normal or slightly minified. Notice in this acquisition, the maxillary dental midline is in fact coincident with the machine midline. However, the patient is pivoting around this point and rotated. Many contemporary panoramic systems have small plastic temple guides that you may place adjacent to the temples of your patient. And as you are placing these against the patient's head, it's important to note that both of those temple guides touch the patient's head simultaneously. And that usually means that the patient's head is symmetrically placed within the imaging system. As well, it is important before you make the acquisition to remove glasses, retainers, dentures, any sort of metal piercings like tongue rings, nose rings, or earrings if that is possible. Sometimes it's not possible. I usually ask patients also to remove necklaces, hair clips and pins, and hearing aids. This is a classic appearance of a patient who has not removed their glasses during the panoramic acquisition. This is a slightly newer, more contemporary device. This is an ear pod. So in this particular patient who probably had long hair, the ear pod was hidden behind the hair and was not seen prior to the acquisition. Sometimes as well, the lead apron or the lead cape can bunch up against the back of the patient's head. This is typical in a particular group of patients who have very, very short necks. And so in these instances, the bunching up of the lead apron can be captured by the imaging system. So one way that you can help alleviate this artifact is you can smooth out the apron on the patient's shoulder and back and tell the patient to relax their shoulders and in fact try to press their shoulders down during the acquisition. Ghost images are a very common and probably the most common artifact on a panoramic image. Ghost images are created any time an object is located between the X-ray tube and the center of rotation of the panoramic system. And if you think about it, there are many anatomical structures that will create ghost images because many of them, in fact, are located between the X-ray tube rotation, center of rotation, and the X-ray tube itself. Most classically, we've demonstrated ghost images with earrings. This is a patient with a couple of earrings, two on the patient's right side and one on the patient's left side. And these are the ghost images on the contralateral side. Notice that the ghost images are larger, so they're magnified because the object to receptor distance is increased. But as well, you'll also note that ghost images tend to be projected more superiorly on the image than the native article, simply because all panoramic systems incorporate some sort of an upward beam angulation to them. And again, the degree of that upward beam angulation is vendor dependent. A number of years ago now, we were interested in understanding how individuals looked at panoramic images and how their eyes tracked across a large panoramic image to find abnormalities. This is a part of a study that we published in 2016 with my graduate student Daniel Turgeon, in which we used an eye tracking device and we challenged students and certified radiologists with a series of images, and we followed their eye movements across the screen. This is simply an image of one such radiograph that we showed them, and the eye tracking system is in the little black rectangular box below. This is one of the images that we showed our participants, and this is the eye tracking data for one fourth-year dental student. The little circles represent the locations that the subject's eyes move to, and the size of the circle reflects the amount of time they spent in that location. And the lines that connect the circles represent their real-time eye movements from point to point across the panoramic image. This particular student actually was able to look throughout the image and was actually very comprehensive in their investigation of the image. In contrast, this student, who underwent the same educational program, seemed only to be interested in the teeth and not really interested in any of the bones that were surrounding the teeth, also found on the panoramic image. This is the ghost image of the cervical spine shown by these blue arrows. The ghost image is superimposed over the maxillary, but probably more prominently the mandibular, central incisors, and canines. It creates a somewhat blurry image of the mandible and some of the maxilla, making it very difficult to resolve detail in these areas. What we also did with our eye tracking system is we looked at each image and we looked at where students were spending the most time on the image. This is a so-called visual heat map that shows two areas where students spent a lot of time. We know this because this is reflected in the orange and red and yellow pigments on the image. You can see that the dental students spent an inordinate amount of time looking at the lower incisors, which is probably where the ghost image was the most prominent. They also spent time looking in the upper left maxilla because there was a supernumerary tooth located in that position. In contrast, this was the heat map of the oral and maxillofacial radiologists. You can see that in contrast to the dental students, the radiologists spent virtually no time looking at the region of the ghost image, because at this point, certified radiologists would know that the ghost image was nothing to be concerned about because they understood the nature and location of the artifact. One new acquisition that vendors have created is the so-called extraoral bite wing. This is a screen capture from a publication in the Journal of the American Dental Association by Chan in 2018. In this particular experiment, these individuals were able to capture 4 conventional digital bite wings using a solid-state sensor, as well as panoramic bite wings made on a panoramic imaging system of the same patient. So you can see the quality of the intraoral images at the top of the screen, and you can see the quality of the panoramic bite wing at the bottom of the screen. What you'll note is that the image of the intraoral bite wings made with the solid-state sensor are much nicer and crisper compared to the extraoral bite wings, which are a little more fuzzy and a little more blurry. The reason for this is because the resolution of panoramic images, whether they are panoramic bite wings or the complete panoramic image, is really only about half as good as the resolution of a contemporary intraoral solid-state sensors. The Chan study actually demonstrated that extraoral bite wings, although they have high to excellent sensitivity for the detection of dental caries, they had moderate to low specificity for caries and crestal bone loss. One of the caveats of this study and one of the warnings of the study was to become aware of a potential increase in the number of false positive caries identifications on panoramic bite wings. And with that, we'll end this session on how to make panoramic radiographs. I'd like to acknowledge 2 former students who were involved in some of the work that I showed you, Ian McKee, who's an orthodontist in Edmonton, and Daniel Turgeon, who is an oral and maxillofacial radiologist in Montreal. Thank you for your time.